Good morning, everyone. Welcome to the January 18th, 2024 Board of County Commissioners Board Work Session. Today, we'll be going over an update with the Sheriff's Office Scout Team. We have Commissioner Edwards in the room with Commissioners Klaus and Commissioner Mejia on Zoom. And with that being said, I will introduce our Scout Team update members.
Yes, thank you, Commissioner, and I'm going to turn it right over to Joe.
Yep.
Are you taking the lead on this? Joe Avalos is with us this morning with the team.
Good morning, Commissioners. My name is Joe Avalos. I'm the Administrator for Olympic Health and Recovery Services. And we're going to talk about the Scout team and what we've been doing for the last year, a little over the last year today. Chief Mencias from the Sheriff's Office was intended to join us, but unfortunately he's out ill today. So we'll cover as best we can from the Sheriff's side. So just first real quickly about Olympic Health and Recovery Services for those that aren't familiar with us. We are a licensed behavioral health agency in the state of Washington. We were formed at the direction of the Thurston Mason Behavioral Health Organization in 2017. That consists of 2 Thurston County Commissioners and 1 Mason County Commissioner. And we still are very much led the same way, 2 Thurston County Commissioners, 1 Mason County Commissioner. We're a unique agency in that our whole mission is really about connecting individuals to recovery support services throughout the region. We do not do traditional behavioral health office-based work. It's all about connecting those folks to the region, to the regional resources in Thurston and Mason County. Oh, there. And so then, just real quickly before we get to Scout, just wanted to highlight the areas of work that we do in the region. 3 main departments: crisis services, which includes the Scout team and the bullet items listed there, jail diversion, and hospital diversion. So the important part about just the continuum of care that our organization provides is really there's continuity throughout. The folks that we see, that the Scout team might see, might also be referred to our homeless outreach team or our lead team. So there's a lot of continuity and connection there. And then of course to the providers in the region as well that are not affiliated with us. So with that, I'm going to turn it over to Jessica Shook. Jessica Shook is the clinical manager for our crisis services team. And I'll pick up Jessica.
All right. Good morning. I am happy to have this chance to talk a little bit about our co-responder model of care. We developed this model of care kind of as we were developing the team, and then modifying aspects of what we do to match the need in the community.
For the folks online, we'll be starting here again in 5 minutes at 9.
Go ahead.
Okay.
Sorry about that.
So some of the main pieces of our model of care for co-responders are that it is behavioral health providers who are really working in partnership with law enforcement. They are responding to individuals in the community who are experiencing a behavioral health crisis, and that crisis can encompass a lot of different aspects. Housing instability, trauma, mental health, substance use disorder, any number of things go into the crisis for those individuals. The behavioral health providers are providing de-escalation primarily. They are arriving, they are working directly with individuals in crisis. And in that de-escalation and that interaction in the community where the clients are, they are able to divert them from potentially entering the criminal justice system. And they are getting them connected to behavioral health services and other appropriate resources without those individuals having to go into a more formal setting, like going to a hospital emergency room, for example, which is expensive and takes a lot of time and can be additionally traumatizing or inappropriate for a lot of people, depending on what they need. This provides a more immediate response to crisis situations because the co-responders are primarily directed by law enforcement need. They're on the radio, they are connected with the deputies who are out in the field, and so they're able to respond in response to what law enforcement is asking for. I spoke about the diversion from the criminal justice system. This results in a decrease in arrests and jail admissions for individuals who are experiencing behavioral health crisis or who kind of exist in that system where they typically are experiencing behavioral health crises. The co-responders, in addition to responding to that initial crisis, they are also doing follow-up with individuals. They're able to coordinate and provide support for family members and caregivers who, in many cases, are making the referrals, are very concerned about their family members, and are an integral part of the safety plan. And this helps them reduce the likelihood of further crisis. Our Scout team is made up of a crisis clinician who is either a bachelor's level or a master's level clinician, and they're paired with a certified peer counselor. We have found that this is an extremely effective way to respond in the community to people who are in crisis. The clinicians are completing risk and need assessments and making referrals as appropriate to other behavioral health supports, other supports in the community, while the certified peer counselors are utilizing their lived experience to connect with those individuals who are in some type of acute crisis. They're able to build rapport, they're able to also provide resources, but they're able to make that individual feel understood, feel safe, feel like someone is there to help them. Our Scout team responds as directed by law enforcement officers, but approximately 50 to 79% of the time, they are not showing up with law enforcement. They are coming afterwards. Law enforcement goes, they establish that there are not safety or criminal issues at play, and they're able to leave and go do other work that they need to do and make the referral to Scout so that Scout can provide the appropriate resources.
Is that, or they're also dispatched by TCOM directly instead of law enforcement, is that right?
And then all of our staff on our Scout team started out on our regular crisis outreach team. So we're able to provide training. They have experience in the community. They have experience in working in that dynamic of a peer counselor and a clinician together. And then they are kind of selected and interview with the Sheriff's Department, and then they receive additional support, onboarding, and training that is specific to their role with the Sheriff's Department.
Okay, I'd like to introduce Tim Lewis. Tim Lewis is a supervisor for our Scout team and actually started with us at OHRS as a co-responder. So definitely some boots on the ground experience as well in there. So,
yeah, and so here it shows quarters 1 through 3. We had received a total of 728 referrals. Of those referrals, 93 of those referrals in those 3 quarters were carryover cases, meaning that if we see an individual who's in crisis and we're referring them to a community partner, we want to ensure that these folks are getting connected. So they will continue to follow up with this individual until that person is connected with an outpatient provider, case manager service. And out of those 93, a total of 554 clients were served. We are a voluntary service program, so some people may choose to not engage with our folks, which is fine. If there are instances where there are concerns of imminent risk, the crisis team may make a referral for this individual to be seen by a designated crisis responder, but we're finding that those outcomes are typically very rare. Less than 13% of the time that the Scout team has contacted an individual, was there a need for them to refer that individual to a DCR. Some of the Scout services that they provide.
very good, sorry.
Yep.
I've got it right here.
So yeah, this was a case that was caught wind on social media. The Scout team was working with this individual who was houseless, also experiencing mental health issues. They were able to work with this individual for over a period of time and ultimately engage this individual to get treatment and to get stabilized on psychiatric medication and to get him reconnected back to his family. So
I want to go back to something that you said about the 13% of individuals, only 13% of the folks that we've seen, and I know this year it's over 600 folks, that only 13% get referred to the emergency department for involuntary evaluation. That's key, because that's a really difficult aspect for somebody to go through, to have to go and have their rights read to them and have to sit for what is a legal evaluation. And if we can de-escalate and defer that in the field, which is what the scout team is doing, that prevents even more trauma of just having to go through that process if it's not necessary. And so, prior to the scout team going out there, that would have been just law enforcement responding and sending folks straight to the emergency department without any further service happening in the community. So that has been a value add, certainly for the sheriff's department, but for us as well. And our whole goal is meeting people where they're at and serving people in the community, preventing unnecessary emergency department visits, and of course, having the right response at the right time. So just want to. All right. Okay, so the fun stuff, the funding breakdown. This has been a very collaborative approach and challenging, but also very creative on our end, and so much so that we're getting a lot of questions from other states, from other regions on how we are making this work, and we're unique in this aspect. We are one of the few, if only, agencies in the state and frankly in the country that is able to bill Medicaid for the Medicaid eligible services that are being provided by not just the scout team, but all of the co-responder teams that we have in the region, with Lacey Mott, with Mason County Sheriff's Office, with the Olympia crew team. We've been very successful at that, and that helps to obviously with sustainability. So right now Medicaid pays about 45% of the services. We also get about 10% of the funding from the ASO through federal and state resources to help with supervision and administration. Our scout team has their own vehicle, and they deploy, they have their own gear. That's through OHRS. So it's the sheriff's office certainly provides help, and they give them nice jackets. I also do want to point out that we do have a couple of scout members in the audience here observing us today. So, and then finally, the local funding comes from Thurston County Treatment Sales Tax, and that pays about 45% of the cost for the total of 4 FTE that we have. And this is in line with how this is working in every other jurisdiction. So with the city of Lacey contributes funding as well. Same thing in Mason County, and then same thing with the city of Olympia. And it's a very good partnership, it's efficient, and helps us to just have long-term sustainability for a program that really works as an alternative to law enforcement response to behavioral health crisis. Is your question, Commissioner?
I do have a question.
Okay.
So when you say it's unique, or why is that 45% Medicaid unique, or in what way is it unique?
Great. So in most co-responder models, first of all, it's usually just one person. It's a one-person model, so it'll be a social worker or a mental health counselor employed or stationed at a police department. That's the typical model, and it's or a fire station, and they're providing a true co-response model where they're deploying side by side with a police officer. That's the model. And most of the time, or all of the time, those jurisdictions are not behavioral health agencies. So that's the caveat, is that in order to bill Medicaid, you have to you have to be a Medicaid eligible behavioral health agency. So by having our scout folks and MOT folks, employees of OHRS is eligible to receive Medicaid services. That's how we're able to draw those down.
That seems smart, but why would other jurisdictions not feel like, oh, that we've got to do it that way so we can get advantage of that funding?
I think that's why there's a lot of questions with us. I think historically, and even for us, there's been a separation with behavioral health. The behavioral health providers are on one side, law enforcement is on the other, and never the two shall meet, or there is siloed for sure. And so that's been one of the, if not the biggest change for us in the partnerships. Because now with our scout folks embedded and MOT folks embedded within each jurisdiction, their relationships are built. They know what the teams can and can't do. They know the scope of practice, and they're able to just build that trust from within. So with that, it has changed a lot for us, for the positive. And
It supports all of our teams at OHRS in terms of having that good working relationship with law enforcement entities, not just the actual co-responder staff,
Right.
but it makes all of the work that we do in terms of getting to the community where people are, it makes that easier.
So you're saying like maybe in other places, there isn't an agency with that level of trust or that's been able to establish that to where law enforcement would use it in the same way as they would somebody that they've got.
that's a big part of it for sure. And so most of the co-responder programs are funded by contract or grants. Usually they're WASPIC grants or other grants or ARPA funds, things like that. Which is great. And in fact, our initial co-responder program with the City of Olympia, which Tim was a part of, was a WASPIC, Washington Sheriff's
Association of Sheriffs and
Police
Police
Chiefs,
Chiefs.
sorry, acronym there. That was a WASPIC grant to start with, and it was so successful. And during the course of that, we were able to see, the services that Tim is providing, they're totally Medicaid eligible. That actually was the kickoff for this. And then the next step was working with the police department on establishing the MOT team and the model, the SAMHSA best practice model of deploying a crisis clinician along with a peer. And that's where we're at. So, any other questions on the funding?
Funding for me.
Are you gonna at some point and ask if we have questions, I take it?
Absolutely,
Or are you,
sure.
can we fire away here?
However you like, sir.
Okay, is it okay?
Go ahead, and then I'll go Commissioner Klaus. I see your hand.
Okay.
Of those, I'll just use that number of 600 that you mentioned. So if it wasn't for you folks doing what you're doing, those 600 would be being dealt with by law enforcement as far as taking them in maybe for an evaluation, tying those officers up. Maybe they end up going to jail. And it's hard to quantify a positive, but do you have any idea how much money you're saving the taxpayers? I know this isn't for free, it's costing taxpayer money, but the efficiency ratio has got to be tremendous when you think about maybe getting people back on the right track. How do you quantify that? How do you quantify the fact that you're not putting people in jail? I mean, and that costs the taxpayers a lot of money. So, I mean, it's kind of a double-edged good deal, you might say. Have you ever tried to put a dollar amount to that?
We're looking at that now. That's part of the analysis we're doing. So it's 600 individuals, but it was actually 3,000 visits over the last year, over calendar year 2023. So in those instances, if Scout wasn't available, that might have been 3,000 extra law enforcement responses that to encounters that really didn't require law enforcement response. So, but it'd be great to work with with the Sheriff's Office folks on helping to quantify what that would look like. What does that mean in terms of FTE, in terms of availability of first responders, and then we can do the same thing on our end as well.
Because what you're doing is so unique around the country, I guess, and around the state. I would think somebody'd be wanting to glean that information so it could be shared somehow. And maybe not with you folks necessarily doing it as much as, grant coming in or some
Absolutely.
group coming in and looking that all over and being able to promote this and then compare it to a mental health hospital that we don't have, or the cost of that hospital, or the whole incarceration, those numbers. And if you looked at that statewide, it's got to be quite a savings.
Commissioner Fournier.
I just want, Commissioner Edwards said it was an alternative, and it said jail. I just want to remind it's either jail or emergency room. So the emergency room is greatly affected or greatly improved by what these folks do as well. And, as we heard from Medic One saying that the rigs will have 45-minute wait times getting people into the ER. Sometimes a lot of those folks in the ER are there kind of inappropriately. So like this intervention helps with the emergency rooms as well.
Commissioner Klaus.
Yeah, I just had a question kind of related to Commissioner Edwards' question about the metrics. And I was wondering two things. The first one is, do you ever find that by having law enforcement respond first, because you said that law enforcement typically responds first, and then once the peer counselors get there, the law enforcement team can leave. Did I hear that correctly? Is that always how that works, or is it sometimes possible for the peer counselor / social worker to be there first, or do you think that poses a safety threat to that secondary team?
That's a great question. I think that there is many combinations in which that outreach can happen. So one of the possibilities for referral would be if there is a call through 911 or someone comes to law enforcement's attention in some way and they're responding, and then maybe the situation is different than what was reported. And so then they are able to leave and pull back. Sometimes they may stay until the scout team gets there. Sometimes they may just go and make the referral for scout to follow up within that day. There are other situations where referrals may come into law enforcement through various channels, and they make the determination to not respond at all, to just send it directly to scout. We do a pretty thorough risk assessment for like the risk of the whole situation when we're responding in the community. So we're asking questions about, are there firearms present? Has there been recent aggressive or assaultive behavior? Are there safety concerns for behavioral health professionals to show up without law enforcement present? So we're able to be specific about if it's needed or not. And then when law enforcement and scout are showing up together or are working with someone together, I think that the scout members can speak to this as well, but my understanding is that in a lot of those situations, it's scout who are taking the lead in those interactions. Law enforcement is there, they're present to provide stability and structure and safety for the situation if needed, but they're not the primary intervention.
Okay, awesome. That's really cool. Thank you. The second part of my question is, when we're talking about metrics, do you all have, so Commissioner Edwards asked a really, really good question. And I know it sounds like we're just kind of starting the conversation around metrics and how to measure this so that we can show the success of the program. And I was wondering, where are we at in that conversation? Do you have specific metrics in mind? And do you, OHRS or the Sheriff's Department, have capacity to evaluate those metrics, or is that something that could be supported through like a third party group? What are your thoughts on that?
Well, we're certainly open to that. We have a ton of data in terms of, because we're an agency, every encounter is recorded, every referral source. And so we are actually building a dashboard now to be able to report that on that specifically, including how many times we respond without law enforcement. I think it's closer to 80%. And I'm looking at our scout team members now that
They're nodding.
they're nodding. So yeah, 8 out of 10 times they're responding without law enforcement. And a lot of that has been because of the training over the last year with the Sheriff's Department and understanding their scope. Not only that, but because we do get a lot of individuals in the region who, you know, are high utilizers or use the crisis and first responder systems quite a bit. We do get to know some of the folks, so that's helpful too. The Sheriff's Office has their own database that our scout folks have access to, and then we have our own electronic health record that where we can look at our own history of our outreaches with them, and that helps in determining safety and risk as well. So the whole goal for all of our outreach programs is to not have law enforcement respond. We need them when it's a safety risk, but the whole partnerships with all of our co-responder teams is really about providing that non-law enforcement response. So we can certainly report on that too. And we'll be doing that at our next update. And I know the Sheriff's Office had some metrics as well that they're tracking too.
So I'd kind of like to so Commissioner Klaus asking about, I'd like to back it up like a step to someone in the public that's observing someone in crisis, in terms of how you get involved or somebody else gets involved with that person. If they call the police for whatever reason, then obviously that's what the scout, but like I'm a person that like I would never call the police almost in any situation unless someone's actually being like, physically harmed. But I see people in crisis or see them doing stuff that might be kind of like, banging on say a door of a car or something. Is that criminal? Well, maybe, I guess, like potential property attempted criminal mischief in the 3rd degree. I mean, but am I going to call the police because somebody's kind of acting crazy and banging on a window? Absolutely not. Never do that. So is there a way for me to help that person or for that person to get help, or does it have to be somebody triggers law enforcement and then the crisis unit? Like, is there a direct pathway to you guys, or is there a direct pathway to some other team? My understanding from Olympia, when I've seen their presentations on crew team, is that you can just call crew team. Like I could call crew team. I don't have to call Olympia Police Department. Is that how it works for your team?
Yes.
Okay.
Yep.
You can call for crisis directly as well. So for our co-responder teams, they are pulling from our quote unquote regular crisis team. So we also have peers and clinicians who are deployed throughout the whole region, through Thurston and Mason counties. And they do some other things too. But so people have an option, because there are a lot of people who, when faced with an unsure situation, they will call 911. There are other people who are more savvy about the crisis system, and they will call our crisis line directly. We refer from our crisis line. We also make referrals to Scout. We utilize them. The primary referral source for Scout is the Sheriff's Department. They get first dibs. But we also refer from our regular crisis line, particularly if it's someone who has had past interaction with Scout. There may be some familiarity there. There may be an extra level of comfort, and we can route them right over to Scout. So it's not going through law enforcement. It's just going directly to a behavioral health response. We want to have as much access as we can. We don't want people to have to jump through hoops or know the secret password. We just want to be able to have them, however they access crisis resources, then we can get somebody out to them.
And there's no I mean, I can describe what I see as a citizen and you can decide whether that warrants a response.
Yeah.
Because I mean, like the other night I saw somebody it was in an empty parking lot downtown, and this guy was just like, I mean, he was a crisis. But he wasn't hurting anyone. He was just swinging his arms and screaming and jumping up and down. I mean, I felt like that person really needed help, but I don't want to call the police. They're not doing anything wrong. I don't want them to touch that system. But I didn't, is it just the crisis line? And then I would describe what I see, and you would say, that's. You've got some criteria as to when to send someone else out.
Yeah.
Yeah, Commissioner Fournier.
When you call 911, you're not calling the police. You're calling a dispatch center that is like a centralized, organization that then decides what type of response is necessary. I wouldn't want to, I don't think I would want to advocate for a system where people have like 15 numbers that, citizens are deciding what is the appropriate, system to activate, because that's really what 911 is designed for.
And then 988 is
and so that that's and so that will be the future. It will be 988, and that's a national crisis line that we do have that in the region now. It's still getting up to speed. 988, and I presented on this I think in November. It still currently receives about 300 calls per month in the Thurston Mason region, whereas our regional crisis line receives about 3,000 calls per month. So it's not quite, and that's statewide. That's not just specific to our region. Statewide, the regional crisis lines, which are run by each of the ASO regions in the state, are still receiving about 90% of the crisis calls. But the intent of the legislature of this state is for 988 to eventually replace and be the main number that is called, and then those 988 folks would dispatch and triage mobile crisis referrals.
So when you call the crisis line, and I don't know what that number is, you mean, would I go to 911 right now, because until there's 988?
No.
Okay, I need to know your number.
Yes.
Okay, that's good to know. Okay, Commissioner Klaus.
Sorry, my hand was still up for my last question.
Okay, very good. Commissioner Edwards.
How would we know, how would the normal citizen know your number so that they could call? I mean, using the example that Commissioner Menser laid out, and they were concerned enough, they want to call somebody. How would they get that? I mean, I know there's certain, they're trying to build up that 988 number so everybody knows it. I went through the 911 thing where, I mean, you know, in law enforcement, it transferred from a 7-digit number to eventually 911, and then it.
And you're right, and frankly, that's still the main hub that people use 911.
Yeah.
When they
I mean,
find folks.
it's
in
short,
crisis.
it's snappy, it's easy to remember, which is the reason that they're moving to 988, because it's easier to remember. Our number, our regional crisis number, historically, it was a number that we inherited from the previous crisis responder, crisis agency. So it's been in the community for a long time, for over 25 years. It's, we're on resource lists, but I think it's a good point that 911 is still, for a lot of people, is the most recognizable, most understandable number. And that is the front door for a lot of behavioral health stuff.
Do you want to get that information? I mean, this, to me, obviously, I sit on the board and stuff, so I know more about this. But for the general public, as far as I know, this is a recorded and meeting that the public, if they have an interest, they're going to watch this. So do you want to put that number out to those folks, and or does that cause you an overload, or is that
No, absolutely.
a brief issue, or what?
No, we're in a little bit of a catch-22 because the state is wanting to move towards 988, and people can call 988 now, and they will transfer to us.
So that's fine. I
It
mean,
will.
I'm not trying to prompt you to do something that would cause you a headache. I just want to know, for those people that are watching that are concerned about this as a topic in our community, and they see what Commissioner Menser saw the other day.
Sure.
What should they do? And if 988 is the answer, fine. If 911 is the answer, fine. I'm not trying to squeeze something out of you.
Sure.
We cause a problem, but I think there are other folks out there that are very concerned about what they see going on in their community and how they can help address it.
I think it's also important to note that while we'll respond to the person that you mentioned and see if they need help, if they don't want help, then that, we'll still do the follow-up, but, there's that, and that does happen from time to time, for sure. They're entitled to not have help as long as they're not in danger or not endangering.
I mean, the person I saw, I don't think was in a position to evaluate whether he wanted help. I mean, you'd just be like,
Yep.
you'd just be, I guess, taking the external cues.
I guess, where do you draw the line between
Sure.
that guy acting out, not hurting or bothering anybody other than he's causing a mild disturbance, you might say, but to where he jumps out in front of traffic going by at 20 miles an hour or 25, whatever, and gets hit by a car, and then, the sad part about that is that not only does that person get damaged, but usually the driver suffers some trauma from, they didn't want to run over somebody,
That does get tricky for sure, and our team that responds, we don't go hands-on. We can't, if the person doesn't want help, then it's really up to our partners and their threshold. Meaning law enforcement, if they're with us, on does that person meet their threshold to go hands-on, and there's risks with that as well too. So it really is.
Yeah, I think that one of the valuable things about the model that we have, and having kind of the behavioral health part of the scout team be under the umbrella of our overall crisis team at OHRS, is that we also have designated crisis responders on our crisis team. And so the ability for consultation, for referral, for handoffs to different kind of levels in the crisis system is made a little bit easier. If Scout team members are out and they are seeing someone who does potentially meet that threshold for imminent risk that we're talking about, they have pretty good access to be able to consult with the DCR and decide if it does need to be an involuntary treatment evaluation. But we're not starting there. We're not starting with involuntary. We can start with meeting the person where they're at.
Commissioner Fournier, is that a new hand or an old hand?
Sorry, old hand.
Commissioner Edwards?
How much interaction do you have at the jail, at the county jail? Do you ever get in where they're having a problem with somebody, you know, I mean, kind of acting out or something, but they're an incarcerated person? So do you try to get in on the ground floor to get to know those individuals? Because they're going to be released before long, and then you're on a first name basis or anything. Is that something you?
Absolutely.
Yeah.
It's just not the
It's
crisis
not my
team.
team.
It's the jail diversion team. So it is still OHRS staff. So the good thing there is that certainly they engage individuals while they're incarcerated, and then they help with release planning as well. So if there's services that are needed outside, once they're discharged, we can help them connect to those two. There is a lot of crosstalk.
I was on the phone with the supervisor for the jail team just a few days ago, and we were talking about an individual who was in jail that we had also seen.
Did you have other parts of your presentation?
I just had a couple more things.
Would you finish that up and then we'll.
Sure. So just, I'm on the coverage hour. So currently we have 4 FTEs, and the staffing hour levels are there now. Those were established. I think we modeled it after the Lacey team hours, and that was at the sheriff's office direction, based off of when evaluations were coming in. I know we met with the sheriff, I want to say it was late last year, or shortly after the proposition passed, or resolution passed, to talk about 24-hour coverage and expanding to that, because I know there's a need, you know, after 6 p.m. the first half of the week, and after 10 p.m. the second half of the week. And so Chief Mencias wanted me to talk about what that would look like in terms of FTE. I think it would require an additional 4 FTE, as well as a part of a supervisor to help with those folks. So we're continuing to work with the sheriff's office on how we can make that happen. As I mentioned before, 45% of the funding is through Medicaid, so we'd have to make sure that there is enough Medicaid to draw down from in order to support that, if we were going to continue to have the same funding model to move forward. So just wanted to put that up there. And that's really it. That's all we had on our part. So happy to take more questions.
I have a question, and I think I might know the answer to this, but if, let's say, like, Crew or Mott, their hours, you know, let's say they're done operating for the evening, and you get a call and you're at this 24-hour coverage capacity, and you get a call about someone who's in Lacey or Olympia, would you be able to respond to that or would that just be a DCR referral?
That's a great question. So I think when we went with the sheriff, we did talk about a regionalization, but that's still way down the road. So that is a possibility for sure.
Yeah.
And with our larger mobile outreach team, we are moving towards 24/7, not just DCR response. But that's still a work in progress, and I think the state is trying to get there as well.
Okay, cool. So this FTE need up here does not cover the whole county, I'm assuming. You would need more people than that to be able to respond outside of unincorporated Thurston County.
Yes.
Yeah,
For sure.
that'd be a heavy lift.
It would be a great place to start.
Yeah.
I would take it, but
Yeah.
we would need more.
Okay, awesome, thank you.
Are you saying if like Lacey's, if Thurston County funded 24 hours, but Lacey didn't, then could
Right.
be a response? Okay, I see.
Would we not need Lacey's authority to operate within the city limits?
Not for the sheriff per se. The sheriff has authority all through the county, but maybe the scout people.
If I were an official in Lacey and Thurston County wanted to pay for after-hours response, I would just
One would
I'd
hope that
say,
they'd love
sure.
that, but,
There's no
I think we
restriction
need to work
on
with the
utilizing
cities.
a deputy sheriff in a municipality.
That's,
Restriction.
And I would
I can
think,
tell you
that
there's no
surprises
restriction.
me because of the way we, address funding and.
Oh, yeah, I know. It's,
Yeah,
it
and-
doesn't
It's an
make
interesting
sense
issue.
always.
I've brought it up a few times.
What's that, Mayor? Oh,
That just that people think that deputies can't work within cities, and
oh,
the sheriff's
I think
department
there's-
does receive funding from people that live in cities, just like people that live out in the county.
sure.
well, and I would say maybe that's for the deputies themselves, but not for our staff. Our staff can go and
We wouldn't be restricted by that,
That's true.
yeah.
Okay. Any other questions for these guys?
Sorry, I have one
Yeah.
more question. Yesterday we were having a conversation with Lacey and, I was told that the scout team is modeled after the Mott team. Is that like, what's the timeline for that? How much do you all like model after other programs?
So the MOT program was the first one, and when I say model, it really was about the staffing pattern, having the model of the clinician and the peer going out as a team, and then looking at how they were trained, how they're embedded within Lacey, and that was this Lacey folks working with the sheriff's office to basically help them. How did you guys, embed these clinicians and peers within your law enforcement culture? So that's a lot of the pieces of the modeling part. For us, for our end, it was about making sure we had the right training for our team, because it is different. It's not like you're in OHRS where you're surrounded by social workers and peers and other clinicians, where now they are with law enforcement. Those are their coworkers, so it's a different culture. So that's what I really meant about how do we make that work, where each is understanding their role.
Awesome, thank you.
Commissioner Fournier?
I want to remark that within the fire service and EMS, there's a lot of discussion, and it's coming up in Thurston County now about, they call it kind of like a CARES program, where they're also looking at ways to embed like a social worker aspect to the EMS side of things, where they assist with medications, they help people get in touch with resources that they need for medical care and social care. And so there is a whole I guess kind of additional aspect to law enforcement and emergency services that is kind of coming up, and there's probably ways to coordinate with EMS and fire. As you guys are social worker aspects of law enforcement, I'm sure that there's ways that you can intersect with Medic One's efforts to bring on like a CARES program.
Absolutely, we would support that for 100%, and we are in pretty good contact with Medic One as it stands, and I think we met with one of the care programs, right?
We went with Lacey Fire.
Lacey, okay. And I know we do the same thing in North Mason County as well.
Okay, thank you so much for being here.
Thank you, we appreciate it.
We'll be adjourned. Commissioners are back at 10:30 for commissioner check-in.